syndrome is real and has been puzzling the dental and medical professions for decades. This is the TMJ TMD Demystified podcast with Dr. Tony Urbanic, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ TMD Demystified podcast.
Welcome. Glad to see you here. Hope you showed up interested in finding out something about temporomandibular joint disorder. This is the Saturday live stream TMD Demystified, and my name is Tony Urbanic. I really appreciate you viewing this, and truly I hope that each and every one of my live streams or podcasts is meaningful to you and that you can take away something for it that you can apply to your patients or your practice, or if you are a patient, that you can apply it to yourself with this if you have these symptoms of temporomandibular joint disorder. Today, before we dive into the topic that I have selected for today, which is a very, very interesting topic, and that is migraine headaches and its relationship to TMD, or if you want to do the opposite, TMD's relationship to migraine headaches. That's what we're going to talk about a little bit. And as usual, I usually plan on discussing and ruminating for 20, at most 30 minutes or so. And as I talk, I have the opportunity for live viewers to ask questions. And if there are questions or comments as I present at the end of the presentation, I'll open it for discussion and comment on your comment or answer your questions. But right now, I want to bring to your attention that this podcast series and this live stream series has been honored from Dentaltown, which is the largest platform for dentists in the United States of America and probably the world. I've been honored as a feature for one of my podcasts, as a featured podcast, several issues ago, probably about 4 to 6 issues ago, which was on the topic of how the petrotympanic fissure, a literal fissure that is associated with the jaw joint, can allow inflammation into the middle ear and create the same symptoms that are associated with Meniere's disease. And I did a podcast on that explaining the whole situation. I'm going to share my screen here, if I may, if this works. And just this week, Dentaltown honored me and this particular podcast, petrotympanic fissure and Meniere's disease, as a featured issue within their platform. And as you can read, I explored the often overlooked connection between temporomandibular joint disease and problems with the inner ear, actually the middle ear, more precisely. There's the external ear, the middle ear, and the internal ear anatomically. But it is well known that there is a structure called the petrotympanic fissure, which can allow inflammatory fluids to progress from the temporomandibular joint and the chronic inflammation within the temporomandibular joint into the middle ear, creating the symptoms that are used by ENT surgeons, otolaryngologists, to define Meniere's disease as ringing in the ears, tinnitus, subjective hearing loss, a feeling of fullness in the ears, like your ears full of water, and dizziness. And those three symptoms are the definition of Meniere's disease, and the ENT doctors have no solution for Meniere's disease, and they admit that they have no solution for those three symptoms. They have a definition of Meniere's disease, which are the symptoms themselves, and they do a very expensive workup to define whether or not you have Meniere's disease, and then offer no solution. And we know that by decreasing inflammation within the temporomandibular joint will decrease the inflammation within the middle ear, which makes the symptoms go away, the non-painful symptoms of TMD. There are painful symptoms of TMD, which I've discussed so many times. The most common are headache, earache, jaw pain, neck pain, upper back and shoulder pain, which moves around all the time. And then the non-painful symptoms of ringing in the ears, tinnitus, subjective hearing loss, fullness in the ears, and dizziness, vertigo. So as we roll this out, I appreciate the honor and being featured by Dentaltown on my most recent issue, actually episode number 247, petrotympanic fissure and the middle ear. To qualify that or to define it just a little bit more, let me see if I can bring up a diagram that I used on that issue to not leave you hanging. This is directly out of Gray's Anatomy, and if you can see my pointer, you can see this is external auditory canal. This is the glenoid fossa, temporal bone, zygomatic arch, temporal bone, external auditory canal, and the glenoid fossa, basically the socket of the ball and socket of the temporomandibular joint. And just to the posterior of the temporomandibular joint is the petrotympanic fissure. Hopefully you can see my pointer, petrotympanic fissure. Looking at that fissure as it enters the bone from the temporomandibular joint. And then if I can show you the other slide on this series. Well, there we go. That's not a good... Let me see if we can enlarge this a little bit. Yeah. There we go. So this is the external and then the internal view. And this is looking at that middle ear from inside the middle ear, and the petrotympanic fissure is also called the Glaserian fissure. If you see my pointer here on the upper left, Glaserian fissure or petrotympanic fissure. It's called the Glaserian fissure because it was originally documented and observed by Dr. Johann Glasser in 1680. That's 1680. That's how far the knowledge of this fissure goes back, and actually allows inflammatory fluid to go through this fissure from the temporomandibular joint into the middle ear, where the mechanisms, those little structures in the middle ear which create hearing, and our vestibular mechanism which keeps us upright, which keeps us stable. And by the way, the chorda tympani, which is the nerve off, the small nerve off of the facial nerve, also runs through the petrotympanic / Glaserian fissure. And that chorda tympani, for you dentists out there, you probably remember this nerve, well documented in your dental career, in your dental training, basic science, which supplies taste to the anterior 2/3 of the tongue. Very important. This particular mechanism may also explain the phenomenon of burning tongue. Inflammatory infiltrates surrounding the chorda tympani as it comes through the petrotympanic fissure. I don't claim this is a may now. This is not fact, but this needs to be explored for sure. This can explain the phenomenon of burning tongue. And we have had patients, when you decrease the inflammation within the temporomandibular joint, it decreases the inflammation within the petrotympanic fissure, allowing inflammation fluids and exudates to get into the middle ear, which then will decrease the burning tongue. We have seen that in some patients. A very important study needs to be done on this, and we have not done that study yet. So I wanted to share that accolade with the viewers, listeners, and I'm very proud that Dental Town, the largest dental platform, has recognized that single podcast that I did, and very important anatomical cell biology concept to be brought a little further and promoted within the dental community, because our dentists, the dentists really are the first line of defense for sure on temporomandibular joint disorder, and most dentists think this is a complicated problem, and it is not. It is not a complicated problem. So we are going to proceed and talk about the relationship between migraine headaches and temporomandibular joint disorder. So let me first of all pull up and come out of here, and we're going to pull up another thing that I have developed in the past couple days for my presentation. I asked AI a couple days ago to give me the three most prominent theories as to what causes migraine headaches. Because I know from experience in treating well over 5,000 temporomandibular joint patients non-surgically with a device and protocol that unloads the temporomandibular joint. That's all this thing does. It unloads the temporomandibular joint according to protocol, 24/7 for 2 months, nighttime only the rest of your life. But that is enough unloading of the temporomandibular joint to decrease the inflammation. And because the inflammation drives each and every one of those symptoms, we've talked just a minute ago about how it literally drives the non-painful symptoms. And we have talked many times before about how it also drives the painful symptoms through the autonomic nervous system. But the point of this short presentation, live stream, is to compare what's going on between migraine headaches and temporomandibular joint disorder. Now, the medical teams, the medical scientists, very good researchers, very well-intentioned, who study migraine headaches, they full well admit that they have no idea what causes migraine headaches. Now, first of all, migraine headaches is really a catch-all phrase which describes really bad recurring headaches. And they describe it in different ways. Headaches so bad that it puts you to bed. One of the distinguishing factors is you get visual disturbances with migraine headaches. But migraine headaches, by definition, by dictionary definition, is really described as a headache on one side. One side of the head most often, can be on two sides, but bad headaches. The catch-all phrase for a bad headache is a migraine. And the doctors, the researchers, the PhDs, and the MDs who study migraine headaches admit they don't know what causes migraine headaches, but there are several theories. So I asked AI to share with me what are the most frequent and accepted theories regarding what causes migraines. And so I'd like to share my screen again. And I'm not going to, for certainly the sake of patients who watch this, we're not going to go too deeply into this, because I will go past some words that you won't understand, and then you'll get blurry-eyed. and kind of not be able to follow anything along. So I don't want to get too deep into the complicated nomenclature of the nervous system or the brain or the brain stem. For my dental colleagues, some of these words will be meaningful, and even you will have some misunderstood words, which is not going to allow us to discuss this with clarity, because you have to understand the words if you're going to understand it with clarity. But the but the first theory, here is my question. Please supply an abstract that shows the 3 most common symptoms explain migraine headaches. So the first is what's called the neurovascular theory, which is the most common, the most dominant theory, and that it has a neurovascular, having to do with the vascular system and the nervous system, progresses through abnormal activation of the trigeminal vascular system. Now, the trigeminal nerve, as the dentists know, is the nerve that supplies sensation to the 3 parts of the face, the upper face, the middle face, and the lower face. Trigeminal, 3 parts. And that it has to do with the vascular system, neurovascular, and it goes on to explain the different types of cellular exudates that are associated with that theory. It's strengths and weaknesses. You can stop at any point, and if you want to stop the video, if you're watching this, as it records, you can stop it and read this for yourself. Let me take this out of here, make it easier. The second theory, remember, there's no fact here, this is theory, is the cortical spreading depression, which is a theory which proposes that the migraine and aura is a propagating wave which goes over the brain itself, which covers the brain itself, and then goes on to stimulating the nervous system and creating pain. And the third theory, and again, here are the strengths and the weaknesses of this theory. And then the third is called the brainstem dysfunction, which is, we know that the coordinator for the nervous system, the coordinator part of the nervous system, is done in the lower brain, and in particular the brain stem, literally the little stem at the bottom of the brain, where all the nuclei, that is the cell bodies of the nervous system, especially the autonomic nervous system, then goes throughout the body for different reasons and different functions. But the brain stem dysfunction, which is a theory for generating migraine headaches, here is the abstract of what AI states, and AI is very neutral, not biased. That's why it's really good to ask questions of AI, because it's not biased. It doesn't have the different kinds of biases that doctors and patients have. It doesn't have confirmation bias. We've talked about confirmation bias and how it doesn't allow doctors to actually open their mind and look at new concepts that may change the paradigm. And here are the strengths and weaknesses of this. And then amazingly so, AI has literally validated the 4th theory relevant to my work, which is how inflammation within the temporomandibular joint creates all these symptoms by stimulating the autonomic nervous system. And that's a very simple concept. This is the painful part, not the non-painful symptoms, which we discussed just a minute or 2 ago, or 10 minutes ago. But the painful part of temporomandibular joint disorder is actually stimulation of the muscles that move the joint, and the stimulation of the muscles from the brainstem. The brainstem says, I see that the joint is inflamed, and this operates the same way on every joint in the body, the knees, the hips, the elbows. And the orthopedic surgeons have known this concept for well over 70 years, and the dentists do not apply this, do not read it apparently, but and think that this joint, temporomandibular joint, is different than any other joint in the body. That may be the reason they didn't read what the orthopedic surgeons already know about joints, and that is when a joint becomes inflamed, because the joint first has to be damaged, and once the joint is damaged, it becomes inflamed. If the inflammation doesn't proceed to normal healing, then we call that chronic inflammation. And when the chronic inflammation reaches a point that it can no longer go to normal healing, then it sends a signal to the brain stem. It says, I'm inflamed, and the brain stem sends signals back down through the autonomic nervous system. I'm going to help you out. Don't move that joint. Tighten up the muscles that move the joint, and wherever the muscles that move this joint are attached, origin or insertion of that muscle, it will pull on the bone, which will stimulate the pain receptors called nociceptors, which are included within the covering of the bone, which is the periosteum. Nociceptors are in the periosteum. The muscles pull on the periosteum, stimulate the nociceptors, pain receptors, which is then recorded back to the brain as pain. And that is the explanation of painful symptoms. And the painful symptoms can not only be for the jaw muscles, but when it goes beyond a certain point, the signal comes down, tighten up the whole head. Hold the jaw still, hold the whole head still, and then hold the whole upper shoulder girdle still. Tighten up these muscles, all of them. And patients will complain of headache, earache, jaw pain, neck pain, upper back and shoulder pain and tightness, arm, hand, finger tingling and numbness, because when the muscles of the side of the neck, we call them strap muscles, scalene muscles, they're little finger muscles that are on the side of the neck, and when they get the signal to tighten up, the joint's inflamed, don't move the joint, tighten everything up. The scalene muscles get tight, and through the scalene muscles go the brachial plexus of nerves, which supply sensation to the arm, hand, and fingers, especially these last two fingers, the fourth and fifth fingers, all of them, but actually more patients complain of tingling and numbness of fingers number 4 and 5, but it can be anywhere on the hand and lower arm. When the brachial plexus gets squeezed, those muscles, that area of the fingers or the hand or the lower arm has tingling or pain, and that is associated with inflammation within the temporomandibular joint. Absolutely a stunning phenomenon. So that is what AI has to say about the theories of temporomandibular, of the theories of migraine headaches, and what we know in comparison about temporomandibular joint disorder, which causes bad headaches of the muscles pulling on the bone of the face, the neck, and patients complain of what they think are migraine headaches and diagnosed as migraine headaches and treated with drugs as migraine headaches and treated with all kinds of symptomatic attempts for relief for migraine headaches, when actually the problem is inflammation within the temporomandibular joint, which can be very easily treated by unloading a joint like a set of crutches unloads a bad knee. If you have a damaged knee, if you have an inflamed knee, and you need surgery, and the orthopedic surgeon explains to you why and how and what he needs to do, and if you say, I don't want you to do any surgery, is there any other option? Well, he'll talk about injections for a while, and he'll do injections. Maybe he might do injections for 2 or 3 years, until then he'll say, well, the injections are not doing any more good. Now we need to do surgery. And if you say, no, I don't want to do surgery, do I have any other options? He would hand you a set of crutches for your knee problem and say, if you stay on these crutches, your knee pain will go away, and he would be correct 100% of the time. And that is precisely what this device does, according to a protocol. And you have to know what you're doing, and Fortunately or unfortunately, it has to be done by a qualified dentist who knows how to use it and educate his patients how to use it, because you have to follow a certain protocol. You don't want to do damage to the mouth or the teeth, use it too little or use it too much, and yes, you can cause problems. But it's very simple. The whole concept is very simple, which I've just explained to you. So I'm watching the live viewers here, and I see we have some people who are actually watching, but I have not seen any questions yet. We've been going on for about 25 minutes now. I think I've made my point about migraine headaches and the relationship of what actually migraines are. Migraine is a catch-all phrase. It is poorly defined. The best definition of migraine headaches is pain on one side of the head. But because of TV, which promotes all kinds of pain medicine for migraine headaches, any kind of bad headache is called a migraine. And the PCPs and the neurologists try to separate the different kinds of headaches, tension headaches, migraine headaches, according to how the symptoms present. But the point is, inflammation from in the temporomandibular joint can present as all kinds of different symptoms. The symptoms can go on for a short period of time. They can carry on for days. They can hurt on one side of the head, or they can cause pain on both sides of the head, directly from inflammation within the temporomandibular joint, confused constantly, misdiagnosed constantly as migraine headaches, both from the patient's point of view, looking at too many advertisements on daytime TV, or from the physician's point of view, who doesn't know about temporomandibular joint disorder and temporomandibular joint disease and the simplicity of how joints operate once they become inflamed, which is physician orthopedic colleagues know all about. And because I'm both a dentist and a physician and an academician with degrees in cell biology and a few other experiences with the National Institute of Health as a fellow, this is really second nature information, which has been in the literature, some of it since 1906. I looked that up quite recently. So with that as an explanation for today, and hopefully you can apply that. If you are a patient, you can apply that to yourself and see whether what I just said doesn't ring true. The issue is, the question is, to my viewers and listeners, does what I explain make sense to you? Same question to my fellow colleagues, both dentist and physician colleagues. Because from a physician experience, from a dentist, you all have gone through basic sciences and should have gotten exposed to this basic information about how the body works. And so my explanation and the visual explanation on the diagrams directly from Gray's Anatomy, does that make sense to you? Because if it doesn't make sense, then we need to go over it again or go into further explanation, because it's really very simple. The whole concept is very simple. TMD is not a complicated disease. Whether you're a patient or you're a doctor, TMD is not a complicated disease. I talked about it within the last 29 minutes and explained both the painful and the non-painful symptoms, which are generated directly from inflammation. And if you can make the inflammation go away within the temporomandibular joint, the symptoms go away, and you can quit running around in circles just trying to treat symptoms with all kind of various drugs, Botox being the most egregious right now. And I just talked to some very enlightened people in that arena who have brought to my attention some really complications that they're seeing using Botox. And I knew eventually it would show up. Eventually you can, even if it works for symptoms, if you use it too long, if you use it too much, you're going to have complications. You're going to have things that you don't want to see. Byproducts of Botox can cause problems over a long period of time. don't need to beat up on Botox. We're just giving you the facts. If it makes sense, that's important. So for those of you who would like to follow me along, I do a Tuesday recorded podcast, and every Saturday at noon I do a live stream and invite people to ask questions, to make comments, and if you'd like, you can criticize, and I'll even talk about your criticism if you'd like to do that. With that being said, I don't see any questions or comments. I'm going to wrap it up for today. I look forward to next Saturday at noon. We'll do this again. I'll invite you to ask questions and comments. But for today, we'll leave it at, I'll see you next Saturday. I am Tony Urbanic, and this is TMD Demystified.